Good afternoon. It's THCB Gang. It's episode 61, happening on July the 8th, 2021. I'm your host, Matthew Holt, founder and publisher of THCB at Bolty Boy on the Twitters. And fine lineup today, and we're just going to discuss soccer, I suspect. Oh, that's all I'm going to talk about. The rest of the bunch here might talk about healthcare now and again. Who we got? We got Kim Bellard, a regular publisher, a regular author on THCB, writing about something I didn't understand at all this week to do with the reabsorption. Michael Millenson, patient safety expert at Health Quality Advisors. Jennifer Benz, employer expert from Siegel Benz. Deven McGraw, our regulatory expert around HIPAA and everything else from these days Entrepreneur at Citizen. And really thrilled to have back Casey Quinlan, patient advocate extraordinaire from the Healthcare is Hilarious blogcast. She's going to tell us a little bit about her adventures in healthcare in the last few weeks and months, which have been rather extensive. So here we are. Looking forward to the chat. So my update is that England made it to the final of a important international soccer tournament for the first time since 1966 when I was 3 years old. So that's all I've been paying attention to this week. We beat Denmark, the mighty nation of Denmark, albeit the one with the best probably social services system in the world. 2-1 yesterday on a very dodgy last-minute penalty, but don't worry about that. We don't care. And we're on to play the Italians on Sunday. So that's my update. Kim, what's yours?
Well, first, I'm curious about this thing you call soccer. Surely you mean football.
No, actually, there's a good question about that. In the 50s and 60s in England, up until then, it was called soccer because it comes from association football. The sock, which is the part of association, was called soccer to distinguish it from rugby football, which was the game. So all this was done by English upper class schoolboys in the sort of late 1860s, 1870s, when they devised the rules for this stuff. Rugby was school.
Eton and Harrow.
Eton, it was Battlefield. Well, actually, it was Charterhouse soccer. Did soccer. They didn't call it Charterhouse. Rugby was a school where they did rugby football. They did call it after the school. And the fancy boarding school I went to called Winchester had its own football called Winchester, own sport called Winchester football, which is very odd and fell out of favor. Although apparently it was the national game of South Africa until about 1870. But anyway, don't worry, for what it's worth. But anyway, yes, and the rest of the world calls it football, but soccer in America distinguish it from that other game.
Well, that didn't go quite the way I thought it was going to go, but thank you for that education. I've been watching, of course, the Delta variant. You know, July 1st came and went. We didn't hit our 70%. There are parts of the country that are well below. In my own state, the county I live in, which is a mixed red and blue state, is about 50%. But the county over, it's down in the 20s. So we're still not out of this thing yet, and who knows what the next variant is going to do to us. So it's quite worrisome still.
Jen, let me go to you next.
Thanks, Matthew. Hi, everyone. My world the last few weeks has been focused a lot on returning to the office and whether people want to, whether they're actually going to quit their jobs, whether they're actually going to get fired if they don't, and so forth, which I think kind of overlaps with what Kim just said with the Delta variant and, how are we going to manage through this kind of next phase of the pandemic? And then, of course, burnout is a huge topic right now, and just the ongoing mental health crisis that's happening across the country. So all happy, easy things to solve for.
Well, we'll solve those in the next hour without any problem at all.
Absolutely.
Michael.
Well, obviously the Delta variant, which I keep on hoping will go public as part of a SPAC, but have somehow have not been able to work that out. Everybody else is going public. Why not the Delta variant? And sticking to the D's, we have drug prices and drug approvals, where the FDA just came out and said, well, you know what? This drug that we approved that doesn't actually work for Alzheimer's, we're only approving it for mild Alzheimer's. So even though it can be prescribed by any doctor for anything, and even though patients are desperate, we're going to pretend that this takes care of the problem. So I think that's going to show up too. It will be interesting. Meanwhile, speaking of back to the office, it turns out that a lot of patients want to go back to the doctor's office rather than staring at their computer screen. They believe in the power of touch and the power of talking to people in person. So the predictions that telehealth would sweep the nation may still be true, but it's not going to be 100%. It's already dropped, what it was, 37% so far. So I think what we're seeing is a small return to normality until, of course, the Delta variant comes in and wipes out the non-believers in vaccines.
No one's gone to the L word yet, so I'll see if Deven or Casey can say. But Deven,
The L word?
Lambda. It's the
Oh,
one
yeah,
after
the
Delta.
new variant.
The new
Oh,
variant.
okay.
No,
You know
next
what?
up in the
Wait,
Greek
wait,
alphabet.
Matthew, shouldn't we call something the English variant at least, so we keep on that
Oh,
same?
no, it was a UK variant. You missed that.
They
That was
missed
the one with spread
epsilon. They missed beta, eta.
Yeah.
At any rate.
You sorority girls may know.
Oh,
which
we
one
had to
it is.
memorize that thing.
I avoided sororities like the plague when I was in uni.
I was told there was not going to be a quiz on the Greek alphabet.
I'll help you, Kim. I'll give you some
Let
pointers.
Deven talk about what you wanted to talk about. Hang on.
No, I was going to say the Delta variant has actually put the mask back on my face indoors, notwithstanding that in California, I don't need to. It's enough to have me worried. So despite being vaccinated, mask is back on. But for me, I've been paying attention to, apparently the president is going to knock on the doors of people to make sure they're vaccinated, which is again spun up a bunch of theories about that's a HIPAA violation for the president or anybody acting on behalf of a public health authority or administrative authority to knock on the door and ask you to present proof of vaccination status. It's not a HIPAA problem, but nevertheless, it's spurned, numerous conversations about, HIPAA keeps me from having to disclose my vaccination status to anyone for any purpose whatsoever. I'm sure Jen is also very familiar with all of this. But HIPAA is really having its heyday with respect to this pandemic. It was a sleepy little law that few people knew about. Now, all of a sudden, it's trending on Twitter. And I'm excited about this, I got to say, even though it pains me to see how wrong people are about all of this.
Well, there's even a Twitter handle, HIPAA Bad Takes.
Oh, yeah, there's
HIPAA,
a number
HIPAA
of them.
spelled HIPPA.
Yeah.
The way that people usually misspell it. Yeah.
Oh, yeah.
I've seen a couple of those, the difference between HIPAA and HIPAA.
Yes, that was a
it.
great one. Yeah, no, I don't feel like I have to be the person on Twitter all the time stamping this stuff out, because there is already an army of sort of HIPAA myth busters out there doing the work. And then, periodically, if there's a question, then I might weigh in, but it has actually been interesting to see the law again, which has largely been a sleeper, getting this much attention.
Well, I
not
must
necessarily
admit,
for a good reason.
Yeah, so I must admit there are two things. One is that, when was it passed? 1996.
That was a statute. It was 96. The regs did not come out and be finalized until 2003 or 2002, 2003.
Only a 6-year gap. So it's a bit like England getting to the semi-final of the European Championships in 96. By 2002, they got to the quarterfinal of the World Cup, and at one point we're leading Brazil. And not everything we do.
Just like that. Yeah.
Right. I do.
We're in soccer zone, and that's fine. Yeah.
Before we get to Casey, and I do want to ask you about the one thing that happened to me this week, which is that my concierge medicine. We were discussing Forward, the expensive concierge medical people who are advertising extensively on YouTube at the moment, before we got on. But my cheap concierge medical folks, One Medical, had a fun game where they sent out the name of 900 people to me, asking me to recheck my email or something in their app. It was unclear what they were asking to do, a bit like the HBO folks. And it looks last week, and they all put all those email addresses in the CC line when they clearly meant to do it in the BCC line. And it sounds like they did that to their entire database, 900 at a time. And so I think I mentioned this on Twitter, and Lucia Savage, and I don't know if you commented, Deven, said that they have to, there was a nuance that, and repeat what you just said before we came on, they have to decide whether or not they have done that's a HIPAA violation. So how does that work, the sort of self-policing?
Well, when you have something that looks like a breach, right, where information got potentially into the hands of a party that wasn't supposed to, and that includes just demographic information, which would include an email address, as long as that was connected to a healthcare facility or a healthcare provider so that it looks like health information. The entity that experiences that actually has to make a determination about what happened to the data and, is there a risk? Was there a low probability of compromise? What when it first came out was called the low pro co. Like what's the likelihood that this data was seen by another person, compromised, et cetera? And that's for the entity that breaches the data to decide. And your response at the time, Matthew, was, well, who would admit that they had a breach? Well, the problem is that you're going to be second guessed by a regulator, especially in a context where something occurred that is this public and likely to get to the regulator's attention and won't be buried under the rug. And you will be penalized daily for every day beyond the breach notification deadline that you did not notify for every person that you should have notified. So there's actually a huge penalty to being wrong. And so, generally entities are pretty conservative and err on the side of notification in instances like this, believe it or not. But if you haven't received any notification from One Medical yet, that's interesting. They have up to 60 days.
I will go and look at I got an email telling me that there was an email and that I should, here we go, yeah. And it says, I'll read it to you. It says, we sent an email that I accidentally exposed to email address. We apologize.
Oh.
Thank you. As we investigate the issue and we confirm the root cause was an internal configuration error, not a security breach. In other words, we screwed up. It wasn't the Russians. Right. Only email addresses where no PHI or personal information was exposed. We ask you to delete that.
Other than your email address,
which goes back to what you just said, Deven, which is I now know my email address and 900 other people's email addresses.
But not just their email addresses, but that they are One Medical patients. That's the issue.
Right.
That's what got exposed. Exactly. So yeah, you got your notice.
I'm okay. I'm supposed to delete the email. Actually, I got to admit,
you can do whatever you want to.
I copied, in order to figure out how many people were in the list, I copied it into a spreadsheet to get the number. So I still have the spreadsheet. So maybe I could now start my own. My own concierge.
Dark web.
I don't know.
The thing about
but just before we leave this, do you think is that enough? Are they good? Are they done according to the?
Well, no. I mean, whether they violated some other HIPAA provision that led to the breach is going to be up to, if OCR investigates them, that's the determination they'll make, because the breach is usually the thing that brings the regulators in the door. Then they look to see why it happened and whether you have if your HIPAA house is in order. Did you do a security risk assessment? Did you deploy safeguards in order to manage the risks that you uncovered? Did you, if you decided not to encrypt data, what was why did this happen? And was the reason why it happened just due to an employee making a mistake, in which case there would probably be no error and no fine? Or was it a systemic cause due to noncompliance with the law?
Well, we will watch that one and find out.
Stay tuned for updates.
Hey, Deven, is the origins of a breach called a breech birth?
No.
All right, we're gonna move on from this topic because like I said, it's going downhill.
Okay, thanks for the dad jokes. Okay.
All right, talking about bad jokes. Not
teeing up the comedy writer with a dad joke that could have been.
All right, let's move to Casey, because we've missed you a long time, Casey, and we know you've been some stuff. So fill us in.
We all thought that 2020 was a lot, and it was. And then for me personally, 2021 became a lot, because, there's a whole bunch of content out on the web, my podcast and, other stuff, talking about like the adventure that ultimately turned into a stage 4 cancer diagnosis in, I want to say it was late February. But anyway, it was, back there somewhere, which pivoted me into a whole other rabbit hole. But it's been an adventure, and side effects management is now a thing here, because 2 weeks ago today, as I sit here, 2 weeks ago today, I was on day 3 of a 5-day hospital stay because of aforementioned medication side effects. But that, that's fine. It tells me what I need to be on the lookout for. It's the only time I have ever been hospitalized. I called 911 myself, so I was with it enough. It's not like I was lying on the floor. But I recognize that I need more than I can get from home. And one of the things that I will observe in the passage up to and then after that, this question about going back to the office and telehealth and how telehealth is on a downward slope, I can see how there's, for a lot of people, yes, it is better to have the person in the room with you. But the thing that I've been doing, because I made a rule 2 weeks ago that I was not leaving my apartment for 2 weeks, because there are, it's a big old concrete step thing in front of my building. There's no steps in my apartment, but I really didn't want to have the, head injury of getting out and down the stairs, which I have done previously. But I even made them bring me home in an ambulance. I haven't gotten that bill yet. That'll be exciting, but fine. I told them, fine, send me a bill. I'll pay for it, but my part of it, it'll be whatever. Medicare covers some of it. Anywho, but home health has been absolutely stellar, and they come here. And I'm in the way of this sort of regular follow through blood work that is required because of the drug that I'm on. And I'm fine with that, but it's like, can we get somebody to come in here and do that? And then if I need to come to the infusion center to get, pumped up with something, fine. But 2 days in a row just is a lot, because the problem is the Mets are in my bones, and particularly in my pelvis, particularly my right pelvis, to the degree that my whole hip structure went cracker dog for a while. But the good news after all of this is that mobility is coming back. I am once again able to walk with a walker, but hey, that's big progress here. And my next goal is to be able to get to walking with a cane as opposed to the walker that I'm using now, but whatever works. And, I've got PT coming to the house. I've got home nursing coming to the house. I'm in a conversation with my oncology team about getting the phlebotomist to come here as opposed to, me go there. And there's no problem with that, because that's something that, home health nurses can do. So that's been a learning curve, and a grateful one. I mean, I'm in the same zone. I think, Kim, I can't remember what state you're in, Kim, but I'm also
Ohio.
in a purple. You're in Ohio. I'm in a purple state. The county where I live has gone blue-ish. It's still a little purple, but blue-ish over the last, let's say, 6 years. And masking is definitely a thing here. I will still mask when someone comes, when the home health people show up, I put my mask on because I don't want to be that guy, and I mean, I'm fully vaccinated. There are friends who come by that's like, okay, you don't need to mask because, it's like you've been here in and out, whatever, and it's fine. But if I go anywhere, I'm going to stay masked because, hello, have you heard about this Delta variant? Now the Lambda thing. But, and plus, yeah, okay, it's a political statement. No, it's not. But if somebody chooses to take it that way, well, that's their problem, So I'm staying masked. I'm getting good home health. Things are improving here. They've reduced the dosage on the medication that we think was the side effects trigger for the problem that hospitalized me, and onward.
Fantastic. Well, it's good. It's so great that you're back. I know you're back to cooking meals and tasting food and stuff. I've seen that, and obviously
the ability to walk. Never underestimate your ability to walk. Be grateful for it.
Absolutely.
If you can't, it's all of a sudden a whole bunch of things just get very difficult.
No, I and having had self-inflicted knee issues by snowboarding the trees in my past, I'm very clear about how important just to have the ability to walk and move around is very key. Can you say a word or two? So are you on regular fee-for-service Medicare, or are you a Medicare Advantage member?
No, I am a regular fee-for-service Medicare person with a supplement. And I did that I did that purposefully.
Yeah.
And one of the things that a lot of people who are aging into Medicare don't know is that there are brokers available for you to work with who they don't charge you money. And if you end up buying a supplement, they end up getting a commission off of that. And also, if you buy, your Part D through a broker, then they continue to get a brokerage commission on that, which I have no problem with. the part where people earn a living, yay, that works for me. I like to earn a living myself. Have you met me? But anyway, it's like, I mean, I'm really back to the level that I had 4 podcasts to package for Wiley for the American College of Emergency Physicians, which arrived just before I went in the hospital. So I told him while I was in the hospital, I said, might take a couple of weeks. Stay tuned. I'll get on it. But I turned all of that in this week and was able to send a nice bill with a comma in it, nice little invoice. So she's back.
Fantastic. And then my last question, everyone's good about that. My last question about it is that there's been going back to the other world, and it continues on. There's been a ton of movement in the last 3 months of either big health systems or big health plans and or private equity and or venture capital going into home care as a whole in all different flavors of it, hospital at home care, home infusion, even the phlebotomists. So Roe, which started out as being the hair and dick pill company, has now bought a home phlebotomist company and a company to visit people around. So there's a lot of activity, obviously, in this space in terms of the business of healthcare.
Yeah.
Is that something you have? Are you
I
running
have
into those kinds of people?
have not received care from any place but Bon Secours. This, it's a big mid-Atlantic system.
Right.
I know that, they go south from here and north from here, but how far in either direction or how far west they can, I lost track. It's, it's not my job to track that. But anyway, Bon Secours has a very, meaty home health service, and they have partnered with or created something called Dispatch Health, which is the sort of step above that sends out NPs and PAs that they can basically do, any procedure or, whatever that is allowed, under their license, they're allowed to do in someone's house within, I'm sure there are strictures.
So that's super interesting. Can I ask you about that? Because Dispatch is is a standalone private company, which has received, I think, 200 million and change. And they're obviously working with Bon Secours as a sub. So what do you actually, when someone from Dispatch shows up, who are they? What do they got? And what
their uniform says is Dispatch Health in part, embroidered permanently on there, Dispatch Health in partnership with Bon Secours.
And are they sending an NP, a doctor?
Well, I've seen NPs, NPAs, because they've come twice. They came at the request of Bon Secours Home Health previous to my hospitalization. And because I was, my blood pressure was really low and, my hydration was the pits. So they came and, took care of that. It didn't, solve the problem, but it kept, it was another couple days and then I called 911. But anyway, then once I got out of the hospital, they wanted me, the Bon Secours bunch wanted me to see my primary care for, a post, discharge physical exam. And I said, well, I have this rule that I'm not leaving the house for 2 weeks. So what can you do for me? And they said, well, we'll send Dispatch Health. I'm like, okay, great. They've been, they've been here before. I'm good with that. And they were the ones, when Dispatch Health showed up the first time, it just said Dispatch Health. The 2 folks that showed up for my post-discharge physical exam had on Dispatch Health in partnership with Bon Secours, which may have been something that happened in the hospital, or they're just slow on retooling the uniforms. I don't know, but
And in terms of equipment, what do they bring? Because kind of question, what do they bring and what do they leave behind?
They didn't. The orders for me didn't include a whole bunch of stuff, so it was mostly just go in, make sure she's alive, and check her vitals and take a sort of an eyeball and whatever. So they didn't arrive with like a giant wad, but they do show up with Pelican cases with a whole lot of stuff in them that look like they could do phlebotomy, and but that wasn't a requirement for that particular visit.
And in terms of going back to the topic that Deven would care about the most, what kind of coordination in terms of the data between what they do and your primary care and hospitals? Have you been aware of how that's working?
It all shows up in the MyChart side of Epic. And that's something that I will say in all of the journey that I've had, starting with my knee replacement last year before, my back went out, and then that turned out to be Mets, but that was later last year. But anyway, all of the places that I have been, outside of Bon Secours and inside Bon Secours have been users of Epic. Except a little bit for radiation oncology. Somehow, even though it looks like a Bon Secours and it's a Bon Secours radiation oncology, whatever, for some reason their stuff doesn't show up in my chart, in my MyChart portal the same way. It's like, it's fine. But
Deven can fix that for you. I can see a smile.
All of the important stuff has been easy to manage on, my phone. And while I was hospitalized, I could keep track of my own lab results and whatever, which is important to me. Knowing WTF is going on. And, as much as I snark about Judy Faulkner and Epic, and I continue to do so, but, I will say that as a user, this has been a positive experience.
All right. Well, that's great to hear. Deven, just want to call you on that. Is how you put out you are the source of truth on putting this stuff out, how data's moving around, and I don't know what would happen if Casey decided to move from Bon Secours to some other system, but right. How you think in general that process of the data transfer, including for these new entities like the dispatches and the heals who go to the home, do you have a sense of how that's going?
Well, I mean, I think it's going well in some spots and not so well in others. Like, again, if everyone is using an Epic system, then the chances that it's getting into MyChart and the chances that the other providers are able to access it as well through Care Anywhere, Care Everywhere, I never remember what exactly it's called, are pretty good. But there are also still places where there are separate instances of Epic where the institutions can't see the data. Not necessarily because the technology doesn't exist, but because the entities themselves have not sort of pulled the switch and allowed for that to happen. There's, the data that Casey speaks of that's available to her in her MyChart is not as comprehensive as the data that she has a right to. None of her images are likely in there. Maybe the reports are, but probably the images themselves are not there, which may be one of the reasons why so much of radiation oncology is not part of the mix. Like there's room for improvement. And then of course, I don't know whether, if she's being seen separate, if she were to start to see another home healthcare provider that was outside of the Bon Secours system, whether that would get piped in as easily as a little unclear.
I will weigh in and say that this home health thing got started by my oncology team. So as a result, first of all, I know what Bon Secours home health is capable of, and it's pretty much anything. And also now with their partnership with Dispatch, they've added services. So I feel like, okay, this is not the worst place to live right now. Not as though I thought it was. When I moved here from New York to Richmond, Virginia, by the way, which is where I live. But when I moved here, I looked around and I thought, well, if you're going to get sick, they've even got a big old academic medical center and, clinical trial and thing and whatever going on down at VCU. So yay team. So if I'm in a good place geographically, and I'm grateful.
Yeah. And when you're being seen in the same system, then the challenges of getting your data moved around disappear. But that's yet another reason why I think entities use data. They sort of wield data control as a weapon, right? Because right. If the more data you give to the patient, the more mobile they are in right. theory, and the more likely they are, if you ever become unhappy with your care at Bon Secours, hopefully right. not, but if you ever, things aren't working out and you want to try something else, then the ability to get that data moved elsewhere then becomes a challenge.
The ability to move it is there,
yeah.
and it's provided to me, and I know how it works. I think a lot of people. Well, I mean, there are a lot of people who are trapped by geography. There aren't any other providers yep. in their area, so they're going to be stuck with whomever. But I do recognize that I have choices. I'm happy with the current universe of care and providers that I have. Should that change, I, being me, know how to make that move and how to direct the move and how. But I do know that for people who are not as up to date on WTF and how to do that, such as me, because of what I do, I know that it's a daunting challenge. And for somebody who's managing a whole family, you know, elder care through pediatrics and whatever, it's like, that's a lot. And, you know, which is where services like, Citizen could come in handy. But that's why you're there. And, if and when I need, I know I can just whistle at you guys.
That's fine. You can wait till you're both on THCB gang again, then you can ask them directly, and it'll happen that way. So let me ask Deven one last question, then go to you, Michael. So Deven, how many people are coming to Citizen who've been at some place like Yvonne Secours and need to move their data somewhere else, or trying to get it together to get a second opinion at Cleveland Clinic or MD Anderson or wherever? Is that the standard use case you're finding for the people coming to you at the moment, or what and how is that process been?
I think it actually really depends on the cancer. So somebody with a really rare cancer where there's not good standard of care for them, or a cancer with a very poor prognosis where the standard of care is go get yourself into a clinical trial, then they want their data so that we can help match them to a clinical trial, which is something that we have. I have found that a lot of cancer patients, especially on first diagnosis, which is not where Casey is, but I mean, she definitely is above and beyond the average, well above the average patient in terms of her level of knowledge and understanding, what she needs to do. But for a lot of folks, they go with whatever they are advised by their oncologist, wherever they're able to get care. And they're fine with that. And they see less of a need necessarily to come to Citizen. It's only when a treatment fails for them, or they reach the point where they have no evidence of disease, but then they find years later that in fact, their cancer has recurred, or it is metastasized, which is what happened to Casey. And lo and behold, they can't get their, they don't have records from the first cancer visit because it was well before this movement to digitize records. It's not available in their portal or through an API. And I think that's a really common use case for us, is going back and retrieving older records for people who have had a recurrence. And again, seeking primary treatment through clinical trial of patients for whom that's really the recommended therapy. So I'll stop.
I actually had to do that process of manually going back and retrieving some records. I've talked here, I had cancer when I was 19 and was treated for it then.
So that was like 3 years ago?
Yeah, 25 years ago.
Yeah, yeah, she's got a portrait in a closet somewhere.
Thank you, Matthew. And when I got into the survivorship program at UCSF, which happened way later than it should have, which is a whole other health data lack of integration story. They needed a lot of information that wasn't in my up-to-date medical records. And it was this very manual process of tracking some of those things down, which just doesn't seem like it should be that hard still.
Yeah.
That was, Jen, how long ago was that you were doing that track down process?
That was about 3.5, 4 years ago.
Okay. So that's well past HIPAA.
Yeah.
well past my job. Right. Okay, Michael, you were trying to get in any earlier, and then we should move the topic over to
So a couple of things. I have a close relative with cancer in the rural Washington, D.C. suburbs. And still, when she uses a doctor in, Baltimore or D.C., whatever, still have to schlep around and do everything. But I have a question about the portability. I went to see a physician outside my normal network, and I asked repeatedly the staff, can you see my records electronically? Oh, no. But I knew that they had Epic, and I knew that, in fact, it was transferable. And when I went to see, I put out PDF, whatever, they didn't look, went to see the doctor knew about it, but the staff repeatedly told me, no, we can't see it. But my question is this: these are both folks in the same geographic area. And when I went on Epic, it was kind of like they had a relationship with each other, right? So we knew that we're sharing in the Metro Chicago area on Epic. On the other hand, if I went to see somebody who is an Epic user in DC instead of Chicago, would they easily be able to get my electronic medical records through Epic? In theory, right? It's all Epic, but I don't think that they could. Deven, could I just say I'm on Epic and here's the magic word, or the hospitals have to agree?
Well, I think it's harder when when you have geographic distance between the providers, even if they're still on Epic. And this was, years ago, I actually had a demonstration of Epic's network for physicians, and they don't allow sort of fishing expeditions. You kind of have to know where the patient's been seen or be searching within a geographic area. But if they knew, they should be able to get it. I mean, that's
if the hospital in DC has no relationship with my hospital in Chicago,
they shouldn't need a relationship.
They shouldn't need. So the doctor should be able to just type in happy community hospital and my name and get it.
And yes, at least by law, whether Epic allows that or not, I think it is really an Epic question and a question of the customers involved in that exchange and whether they have turned on search capabilities and query capabilities and things like that.
And whether in theory your doctor 600 miles away is going to believe in that and do it and all the rest of that. I mean, it really points to the difference between, as we see all the time, healthcare and other industries about, what electronic data exchange actually means.
Yep. And now you've got information blocking actually, where it's no longer about discretion. Oh, maybe I'll send it and maybe I won't.
Well,
you also don't have to have a direct. Sorry, Kim. I was going to quickly say you also now under the under TEFCA, right? Under the
no, there's no TEFCA.
What?
That's a voluntary network that has not even been installed yet. So there ain't no TEFCA.
I thought doesn't Cures say that you have to have the right to, but isn't what was the thing that we just passed?
You're talking about the information blocking rules. Those are not TEFCA. Those are two separate things.
I should never bring this up with Deven because it's ridiculous to talk about this stuff. But doesn't that give me the right to deputize citizen or health gorilla or somebody to go get it for me?
As a patient? Yes, in theory, but the law's not being enforced yet.
So basically, there are not a lot of penalties. What they've also talked about is that it's not going to be enforced and it's not penalties. So it's kind of like Matthew, if you're stopped by a police officer on a dark night on a street and you look at him and say, officer, I have the right to write down your badge number and report you. Is that really a right that you have?
Depends who you are.
I don't see the analogy, but yeah, I mean, it's a right. Yeah. It's a right and an obligation in the law that for which there are no penalties for violating it. So
my comic example is my wife has a doctor at the Cleveland Clinic, and she wanted to get imaging locally here at the university system. So the doctor in Cleveland had to send her a paper. They're both on Epic. She's got different URL, different logins for them. The doctor in Cleveland had to send her a paper referral, which she took to the local UC place to do the imaging. Then they had to give her a disc to take back to Cleveland to give to them. And this is all on Epic. I mean, this is
all on Epic.
Is this 2021 for God's sake?
And by the way, in all seriousness, at a moment, a friend of mine is a senior physician at Northwestern when they bought other hospitals that were on Epic and had to pay them tens or hundreds of thousands of dollars to make it all work. And I said, why don't you all get together and file a class action suit? It is absurd that the users of Epic put up with this. Now, to be fair, your wife was inconvenienced, but it wasn't that inconvenient for the doctors. So really, why bother suing? The only people who are suffering here are the patients. Now, if the doctors were suffering more, maybe we get that class action suit.
Yeah, I don't know if any of you follow Matthew Cortland at MattBC on Twitter. Mm-hmm. He's a disabled lawyer, and his, obviously one of his lanes is disability law. And he had a Twitter thread up recently within the last week or so about his experience. And this was with Mass General and, trying and, an Epic installation. It was just terrible. It was the worst. And he's even more savvy than I am. And just had, it was a marriage show. We'll just put it that way.
Well, going back to Matthew's point, I don't know of any doctors who use Epic who are not inconvenienced by it. So I don't know why they're not all suing.
Well, but they're all inconvenienced because they actually have to do a lot more work on Epic than they did when they were writing down on paper. And that's
the class action would be the fact that Epic makes its systems non-compatible. So if you're a hospital system that's paying them millions, you then have to pay them hundreds of thousands of more to get your Epic to work with other Epics.
I would argue that it's the hospital systems that are doing that. I think Epic is perfectly capable of doing this. I think the hospital systems are blocking it intentionally as a competitive advantage.
But that's also Devin's point, right?
They block it between competitors, but I'm talking about when you buy something that Epic 1 doesn't work with Epic 2. I mean, who do they think they are? Apple? I mean, it really doesn't.
But all Apple products work together. So that's not a good enough.
They do.
But having said that, Michael, the cause of action would be what? Breach of contract? There would have to be guarantees in the contract of the kind of liquidity that I think we're all seeking as a public benefit, but it's not clear to me that that's what the hospitals signed up for, or outlined that that's what they would insist on wanting. And if they have what is essentially an interoperability pig in a poke, but that's what they bought, there's no lawsuit.
And I actually had just done a whole bunch of interviews with hospital CIOs about a related topic. And a lot of them are talking about their strategy now, because many of these hospital systems, especially some of the big ones, have done so many mergers, and they're doing little acquisitions you don't hear about. Even if a couple of big chains merge, there's a whole bunch of little acquisitions of physician offices and infusion companies and other smaller hospitals all the time you never hear about. And all of these people, as one CIO said to me, we've got a fantastic PowerPoint that shows how everyone's on the one interoperable, fantastic singing and dancing Epic system. But in reality, as we bring these people on, it takes a year, it takes 2 years, it takes 3 years to get this done. And by the way, we might sell them on to somebody else or buy something else. So this is never done. We're always in this complete mess that's going on. That's just the life of running one of these big hospital systems. And just to throw one more thing in there, don't forget, we don't have Jonathan Bush on today, but if he was here, he'd say, well, I'm building, which is his new thing, Zeus, I'm building the Lego building blocks for all of these new companies, whether it's his wife's companies, Firefly Health or City Block, or all of these new medical groups who are essentially trying to go around the current hospital system, and eventually, if they get it right, long time maybe in the future, put a whole bunch of them out of business. And maybe Dispatch Health goes down that path later if it stops working with, just the big incumbents like Bon Secours. How does that all? This stuff is never ending, right? And we're going to have the same issue with information transfer and information blocking. It's just going to be like, when Shopify and Amazon finally declare war to the death about whose stuff you're buying from, whose platform you're buying from online. Are they going to start sharing data so that the store that goes from one to the other can easily move it? I bet you that doesn't happen either. So I think this is, we're going to run and run. All right, I'm going to declare, we were supposed to talk about this for 20 minutes, and we're now 45 minutes into the call. So I want to get back to what we think is going to happen about Society, Delta, Lambda, and everything else variants. Given my interest in watching super spreader events in Europe on TV, as there were apparently 70,000 people in the stadium last night watching while the Delta variant is now going crazy in the UK, and they're going to let a few people from Italy to come in to take it for the Sunday game, to take it back to the rest of Italy. And we've seen, I'm sure you've all seen these charts put up. Charles Gabber on Twitter has put up some amazing charts about the ratio, the relationship between counties where people voted for Biden heavily versus voted for Trump heavily, and how that's exactly mirrored in the downward slope is exactly mirrored in the number of vaccines that have been adopted in the States, and how it's slowing down. And as Deven says, apparently Joe Biden is knocking on all of our doors. I missed the Joe Biden knocking on the door part, but
that's relatively fresh news that happened within today.
So he started knocking on doors today. It's a good news.
Well, the announcement that they were planning on doing that.
It sounds like a good use of the president's time to go.
Why don't they run ads showing that Donald Trump was vaccinated? I mean, that's what I don't understand. Is that rather than making it a red-blue thing, show.
Then all the Biden people will stop getting vaccinated.
Show Mitch McConnell's vaccination card, right? I mean, Donald Trump's vaccination. You have Donald Trump on record, on in recorded record saying, yes, I was vaccinated. I mean, why let this be a Joe Biden knocking on your door?
But I want to go back to Jen on this, right? So what are you hearing? There's the return to work, not return to work. vaccine passports. We had the Carnival Cruise. We had a couple of weeks ago, we talked about the Carnival Cruise line about Florida State almost is what they wanted to do. Jen, what are you hearing from the big employers you're talking to about what they're actually going to do and what they're actually going to impose on their employees?
Yeah, well, a lot of companies are still moving very slowly and don't have dates to bring people in very large numbers back to the office until September or October. But then we have this kind of early wave of the financial services companies kind of making big statements about everyone has to come back and so forth. So I think it's going to be a little bit all over the map for the next few months. And a lot of it is being dictated by the whims of the C-suite right now, where that's, kind of creating these adversarial relationships with the employees, which is not necessarily the best way to run a company after everyone's just been through this huge pandemic and kind of had a reawakening about what they want from their work and life. So I think it's going to be all over the place, but a lot of our clients are taking a slow, conservative approach if they can, recognizing, of course, that higher ed institutions, healthcare systems, retailers, and so forth, they've had people working this whole time, and they're just having to navigate all of the local regulations around it.
Are the people who've been in the, working the whole time, essential workers, I'm thinking, you work with a lot of city and state government, employees, sanitation workers, God knows who else, and obviously retail, the people who, and then hospitality, that's a group where you got to be there. It's hard to, half of the guy to come and empty my trash in the morning, sitting in his office on Zoom, right? We've seen hospitals, a bunch of them have gone back and come and said, you're going to have to get vaccinated. And the ones in Texas fired a bunch of people, not that many, 100 out of 30,000 didn't do it. But I mean, where do you think they end up on the, you've got to get vaccinated, as part of coming back to work?
I haven't seen any data on how many hospital systems are requiring vaccines versus not. Just kind of anecdotally, you hear stories about some of the rural hospitals that have very, very low vaccination rates, even of their own staff. So that feels to me like that's going to be a bit scattered as well. That we're not going to see a consistent point of view on it. You're going to have some systems that take a really bold stance, and then others that just kind of go with what their folks want. But that I think is going to be really interesting if you match healthcare workers not being vaccinated with some of the new variants in areas that have low vaccination rates. That just feels like a bad combination.
Well, don't we have the EUA problem? Like, I understand, like, the military can't mandate the vaccine because it's only an EUA approval as a full approval. Do employers have this same issue that they can't mandate things as long as it's only a emergency use authorization?
No, they can mandate things. And Deven can speak to the technicalities around it probably better than I can, but tons of higher ed institutions are mandating that all of their employees get vaccinated.
And students as well. I assume they can insist on students too.
Yeah. I mean, I actually think that healthcare organizations can mandate it. The problem is going to be that if you end up with a significant labor shortage, because you can't have enough staff to work in your hospital because of people refusing to be vaccinated, and so therefore they're off of work. And suddenly you don't have enough nurses, you don't have enough home health, you don't have enough aides, you don't have enough doctors, and in a low vaccine area where your COVID cases are starting to spike, you don't have anybody to take care of anybody. So I think that's the question that comes before them more than, oh, can I legally mandate this or not? It's that, well, what's the consequence if I do? Because I think they can in a way that any other business can, because those are employees, and so there's not a HIPAA issue, even though you're talking about hospitals doing this. But it's still then what do you do? What do you do if half your staff can't come to work?
Yeah. And there's tons of labor shortage issues going on right now, which is a layer in all of the workplace decisions. And so I totally agree. If you're in a place where your staff doesn't want to get vaccinated, but you need them at work, you're not going to force them to do something that's going to drive them out the door.
So Jen, on that labor shortage issue, I've seen a bunch of reasons why people, one of them is, the right wing is saying it's because unemployment payments are too high, and the left wing is saying it's because the minimum wage is too low and wage rates are too low. We're hearing this a lot in hospitality and retail. Can't get the staff some of it's because, I mean, there was a great article about Mark Zuckerberg going across Lake Tahoe on his hoverboard or waving the American flag and everyone making fun of him. But up in Lake Tahoe, like a big tourist area, everyone from the Bay Area who could work remotely has moved up there, and now you can't get housing to put, the person who works in the coffee shop or whatever, can't find anywhere to live. So you've got a bunch of intermingling problems. So what do you think is the issue where we still have relatively high unemployment? Why are we having trouble getting some of these people back to work? What do you think is the underlying problem, and how is it fixable?
I think the underlying problem is that a lot of those jobs suck. I mean, like, that's just the easiest way to say it.
I mean, it was hard to fill those jobs before.
I guess so. We need robots. Robots is the
Yeah.
answer.
It was hard to fill those jobs before. The sectors that are finding a hard time, are having a hard time finding people now, are the ones that had to lay off a ton of people. So, a lot of people who worked in food services figured out something else to do. A lot of people who worked in retail figured out something else to do. And childcare is a huge issue. If you're not sure that your kid is going to go back to school in the fall, or you had a kid at home all spring, how are you going to be able to go look for another job or take another job? So I think it's a lot of different factors. I don't think it's because the benefits are so high that we're just encouraging people to sit around and watch Hulu all day.
But then you get free Hulu as part of being unemployed. It's not a bad deal. It's quite expensive. Yeah.
There are companies trying to make streaming services an employee benefit, which I think is questionable.
Well, now they're working at home. I do know, talking about streaming services and unemployment. My au pair girl is off for the middle part of the day, and my daughter is next door watching, playing something on my computer. God knows what. But it's the best babysitter you can find, right? This stage. All right, amazing. To me, that's we can all chime in on this, and I know Kim and Michael, you thought about this a lot, but we're not quite back to normalcy yet.
Normal is a dryer setting, dude.
Well, I mean, that's true. But the one thing I did hear is apparently July the 4th weekend air travel, the TSA, was up to where it was in 2019. So at least, we're traveling to places where you can't find someone to serve you a cup of coffee when you get there. But apparently the airlines are back. And although I did talk to an airline mechanic yesterday who came to look at the car I'm selling, and he said that they laid a lot of people off. They hired them back because of the government subsidies for the airlines, but a lot of them for a long period of time have been sitting around not doing much. I think that maybe there's a lot to shake out in the economy as that goes forward, and obviously that has huge impacts for employee benefits, healthcare, and everything else. So it's pretty interesting.
Yeah, I flew back in June. I went to see my parents in Florida. Airport was packed. Flight was packed. People masked in the terminals, people masked on the plane. No issues there, but it was tight. And of course, nothing's talking about not having someone to serve you coffee, like the shops and stuff in the airport, like many of them are still closed. They're not fully reopened. So, God forbid you need a cup of coffee when you get to the airport in the morning. Good luck.
Yeah. It's like my brother, bless his heart, who lives in San Diego, flew here in late May to, visit for a week. And, those were not great days, but he showed up. And, I was like, dude, I love you because you were willing to get on a plane. I'm not traveling again. I mean, some of it has to do with the mobility issue, but I'm not traveling again until fourth quarter this year. And at that point, I'm willing to get on Amtrak. I'm not getting on a plane again until next year.
We shall all see. I have my first trip coming out to Vegas for HIMSS next month. So I'll tell you how long it'll be, and anyone who's watching this, I'll happily buy them a drink. But when I say I buy them a drink, I'll invite them to a party that somebody else is paying for the drink.
Yeah, right. Exactly.
No one's buying a drink. I'm not paying myself for the drink.
Good plan.
All right, fantastic. All right, well, we're getting close to the end, but before I get there, before we get to the roundup, do you want to quickly touch on the Delta, Lambda, or whatever variant? The data I saw, which is pretty frightening, was that people who were properly vaccinated with Pfizer in Israel it was about 65% effective against the Delta variant. Actually, Shah said that data sounds like it might be understated. Now, having said that, when they first came out with the vaccines and had the first clinical trials, the Moderna folks said they would have been happy with 80%. And the fact it was 95% was a miracle. And 65% seems to be not far away from where J&J was. But I guess, does anyone have a sense about whether, because there's so much of the world and good chunks of the US and elsewhere that are not vaccinated, that these variants are going to change and essentially that these vaccines, the vaccines we had, the quote unquote vaccine miracle, is going to fade away and we're going to be in this state for a long time? Does anyone have a sense of that? I guess that's little data, but does anyone want to speculate about what that might mean? Kim, you're usually good for random speculation. We go to you.
They will continue to mutate. That they don't necessarily mutate into things that are more virulent, though. I mean, they could mutate into things that are more like the cold. We don't know. On the Pfizer thing. So I've read mixed things about this. Like one study came out today that said that if you get one dose of Pfizer and AstraZeneca, I think it was, you're still have a lack of protection, but if you get two, you're pretty good. Then there was an Israeli study that said, even two is not enough. So I'm not quite clear about what the level of protection is with two vaccine. Or Casey?
Well, I'll weigh in and say that because I have a lot of connections in the various organ transplant communities and also just generally immune compromised, immune impact, disease states, which include some cancer patients, that vaccinating that population and those folks who wanted to be vaccinated, obviously, blew the doors down early on. But there's some discussion now about needing a booster for them, a third shot. And there are places, I think France is one where folks, particularly in the transplant community who are, on immune suppression drugs, are getting a third jab. And I'm thinking, you heard it here first, probably not, but here it is, that all of us are going to wind up being told that we're going to need boosters at some cadence. Because, what viruses do is they mutate.
Yeah. Well, I mean, and if you think about the regular flu shot, we have to get a new one every year because the virus has different characteristics, and which, by the way, flu shots on average have 40 to 60% risk reduction efficacy. So that even the numbers from those studies that show a dip in Pfizer's efficacy against the Delta variant still put it within the range of efficacy of flu shot. And what we also don't know is the extent to which, maybe it's less protective in terms of whether you get the virus or not, whether you get sick, but maybe it keeps your symptoms from being deadly. It will keep you from dying. You might get sick, you might feel like crap for a week, but you won't die. Because that's another effect. Because there have been some breakthrough infections.
Hospitalized among us, I will say the not dying part is very appealing to me.
Yeah.
Hey, Casey, do you want to predict how long the booster shots will be free?
I think that maybe the first time, and after that we're on our own. But
I suspect.
The flu shot, because I went without insurance for a number of years. I know cash prices on stuff or how to find them. And the flu shot typically was $25 or less. So,
with insurance. Yeah,
cash price at Target or Walmart. Because
I've paid $20 for cash price at CVS before now, which is a lot.
The other thing that's interesting that's not talked, we like to talk about red, blue kind of thing. But, as I mentioned, that Trump was inoculated, McConnell and those people, we don't talk about is social class, right? It's easier to talk about politics, right? And if in fact, members of Congress and congressional staff had a lot of their friends and acquaintances who were sick or dying, I think we'd see a lot different political calculus than we see. And so you can look at, for instance, the county I live in, you can look and you can see the numbers on the people who have gotten sick or died. But that's my county. I don't live in a county. I live within a certain community. And so how many people do I know who got COVID and got really sick and got hospitalized, or a mild case, right? And I think the impact on the people who are calling for Uber, not working for Uber, or getting their groceries delivered, not delivering them, is one of the reasons that we've had some of the consequences we have, apart from the political tribes.
All right. It's right at the end of our hour, so I'm going to make sure that we go our final round real quick. Okay, we're going to whip round and say, what are we expecting? What are we thinking about? What is going to be on our radar? What are we talking about in the next couple of weeks? And I'm going to start with Kim.
Well, I'm waiting to see whether Congress can actually pass any kind of bill. So the infrastructure bill seems to have gone nowhere because it's gotten tied up with reconciliation. The Dems can't agree with themselves. The China bill, which passed the Senate overwhelmingly, is now stuck in the House because they can't agree with themselves. So I'm worried that we're going to go out of 2020 with no major bills at all. So it's very concerning.
Deven.
Oh, how do I beat that? I'm sort of very interested. We didn't get a chance to talk about the no surprise billing new requirements, and so I'm sort of interested to see more about what that all means, since it sort of snuck up on me and was somewhat of a surprise development that I missed.
Surprise, you might say.
I was surprised.
Surprised by the surprises, and yeah. Casey will be surprising us soon with that ambulance bill, so we'll find out. Michael.
Well, I think what we're starting to see is a tug and pull between, are we having normalization, in which case we can worry about surprise billing and infrastructure and those terrible drug prices and all the rest of the things we always worry about? Are we going to be back to worrying about dying from a plague? And, I think that's not something that's going to happen in the next week or so, but that's where we're trending. And so we can all enjoy getting on a plane and going out to some place and having unmasked fun together. And then will come the reckoning in the fall or the winter.
Jen.
Yeah, I agree with Michael that it's kind of take advantage of the summer while we can, with a little bit of confidence around safety. I also think the No Surprises Act is going to be very interesting to see how that unfolds, and if it really makes an impact, or if it's going to just be a ton of work without really much of a outcome.
And Casey, let's end with you. What are you expecting?
Like Deven, because one of my interests has always been price transparency and cost, awareness in healthcare. Watching the fistfights that are now emerging from the surprise billing discussion, on the Hill and elsewhere. And I also am keeping an eye on the variant question. And I mean, they've said that the Olympics will not have spectators. No spectators. You cannot go to the Olympics. Forget it. If you bought your tickets, start negotiating, getting your money back. But, to me, that makes sense. I felt better about the whole thing. But it just the variants are worrying enough that we're not out of the woods yet by any stretch.
All right. So that is the end of another THCB gang out of the woods. I will be looking at another sporting event, not the Olympics, starting on Sunday at about 12 noon California time. There'll be a super spreader event at Wembley Stadium, and we'll see how the variants work there, and of course, more importantly, whether England can actually get to win a damn thing for the first time since I was 3 years old. This has been the THCB gang, episode 61. I was your host, Matthew Holt. I want to thank my guests, Kim Bellard from Cincinnati, Michael Millenson, all the way from Chicago, Casey Quinlan. So great to have you back, Casey. Thanks so much. And you can follow up on the Healthcare is Hilarious podcast, which is usually hilarious, and it's been a bit more serious the last few weeks, from Richmond, Virginia. Jen Benz, hanging out today in Colorado, but usually in San Francisco. And Deven McGraw from the wilds of the Russian River, somewhere in Northern California. I want to thank all of you for watching and or listening on the podcast. This is Matthew Holt saying I'll see you back again on next week, next Thursday, same time, same place at 1 p.m. Pacific, 4 p.m. Eastern. With that, look forward to seeing you all soon. Thank you very much for listening.